Welcome and thank you for joining the DSRIP Lessons Learned from New York conference call. At this time, all participants will be on listen-only mode until the question and answer session for today's call. We would also like to inform you that this call is being recorded, and if you have any objections, you may now disconnect. And now, I would like to turn the call over to the host of today's call, Michael Valenia. Thank you, and sir, you may begin.
Thank you, Chris. This is Vidhu Shekhar. Thank you, everyone, for taking the time to join us today. We've been working closely with Pierce County ACH, Better Health Together, and Southwest HCH on the DSRIP program. I'm a manager with KPMG and leading some of our work in Washington. We really wanted to keep this session as a lessons learned from practitioners in New York to the practitioners in Washington. We'll hope to make this very interactive along the way. We will go through the sections of the webinar, and as you have questions, you can press *1 and you would be connected to the operator and ask the question, and we can patch you through to have the question asked to the speaker. The agenda for us is really to go through the lessons learned from the 6 different entities that Grace has been a part of. Grace, thank you so much for taking the time from your busy schedule to do this webinar for the group. Grace has been a part of several different of the PPSs in New York City and has held a number of titles, including the CFO and VP of Network Services and Strategy as well. Grace, are you feeling ready for this?
Sure, I'm ready. Good afternoon, everyone. Just in way of background, I have been involved with DSRIP for a while. Before I got involved with DSRIP, I was the principal investigator of Brooklyn Healthcare Improvement Project, which is actually a $1 million grant from New York State. At the time, it's to develop a multi-stakeholder organization to find out ways to reduce ED visits and unnecessary admissions. Now, at that time, that was 2009. It go on for a few years, so that is almost like beginning of DSRIP. Although we don't have any money at that time, but we already went through survey like 11,000 patients in the ED, as well as we do a block-by-block survey about, what's going on in the market in Brooklyn, which is 1.1 million lives. So right now, what I'm doing now is the subject matter expert for DSRIP at One City Health. And One City Health is the largest PPS in New York, and it's awarded $1.2 billion if you can earn the dollars. And prior to that, I was the VP and CFO of Northwell in Medicaid Strategies. Now, Northwell is involved with 4 PPS. And I want to give you a little bit of experience from each one of them. Maybe one of your organization can relate to. Of course, prior to that, I was VP Managed Care and CFO at Presbyterian, health plans, as well as Downstate Medical Center. So besides about me, let's go to say what we do in New York in terms of PPS. Now, the 5 PPS that I'm involved at is One City Health, I said before. In this particular PPS, it's actually sponsored by New York City Health and Hospital Corp, which has it's pretty much the largest municipal system in the United States. We have like 11 hospitals as well as 6 long-term care facilities and with 70 different ambulatory care sites. Now, it covers 4 boroughs and it has a central service organization. So it's really One City Health is a wholly owned subsidiary of New York City Health and Hospital Corp. Now, the other 4 that I was involved when I was in Northwell, that's advocate community partners. I think that you have a webinar with them before with Dave Steinman. That is the 2nd largest PPS in New York. And it's pretty much run by the physicians, by the IPAs. Now, the 3rd one, Staten Island. Staten Island is one of the 5 boroughs in New York. It has 180,000 lives, for the evaluation. Now, if you look at the first column, attributed lives of evaluation, there's a lot of lives that, is evaluation, but however, in terms of performance, it's a little less. It is a very unique area. Staten Island, it doesn't really easy to get to, so then they have a pretty much unique confined area. And then the way it is in Staten Island, there are only 2 hospital systems. So in a way, they're like 50-50 ownership. So they call it hubs, 2 hubs. So it's controlled by 2 hubs, but then they have 1 CEO, right, managing the hub. Nassau, Queens. Nassau, Queens is Nassau County in a part in Long Island, and Queens is another borough of Manhattan, of New York City. Now, for Nassau, Queens, we're talking about, it is Nassau, Queens is actually run by a county facility, the Nassau University Center. So in a way, it's a Nassau County. And basically, it has composed of 3 hubs, basically 3 competing systems, and part of the so-called Nassau Queens. So you can imagine it's almost like have 3 PPS together, have a big super PPS on top of it, so it's like 3 hub structure. Same thing with Suffolk. Suffolk is also in 1 Suffolk County, but however, there are 3 competing facilities. They run individual hubs. So it sounds a little bit complicated, and it is. Because the hub, so for example, in Suffolk, you have a Stony Brook University Medical Center, which is, have major academic medical center at the Northwell. And then there's the Catholic health system. So they all compete with each other. However, through district, they have to work together, achieve the common goal. So that's how it's structured. So in terms of total award, it's more, with the 5 PPS, it's more than $2 billion. And in terms of the lives it's managing, it's more than 2 million lives. They're accountable for performance. Is there any questions so far?
Great. Just to add a little bit of context, I think, for our participants, right? Washington is modeled very similarly after the DSRIP program, but has about a total of 1 million Medicaid lives, and the total award for DSRIP is about $1.12 billion. The governance model in discussions right now, at least with the 3 ACHs, is very similar, where they're looking at sort of that collaborative or the cohort model under the ACH as well. So I think, we'll probably have more questions as we get into the governance piece of this.
Yes, I definitely want to talk about that, because there's a lot of tricky landmines, when you're trying to talk about different hubs working together and who's doing what. All right, so, if you want to hold the questions or later, I could move on.
Yeah, let's jump into governance and stakeholder engagement.
Yeah, why don't we do that? So, in terms of overview of governance, committee structure, patient demographics. Okay, so if you go back to the previous slide. Now, One City Health, as I said before, is in a wholly owned subsidiary by H&H, the Health and Hospital Corp. So whatever it does, the committee, there are many committees. There are nominating committee, to the One City Health, executive committee. The care model committees, business operations and IT committee, and stakeholder and patient engagement committee. Now, those are the major committee, and there's a PAC committee. It's basically the project advisory committee. Now, within those committees, at the beginning, they actually have 4 hubs. Each borough does a hub model within one city, although it's governed by all the same committees. But however, those hubs after a couple years doesn't really work. So what happened is that now they kind of combine some of the hubs. But of course, everything's evolving. It depends on, later on we'll talk about VBP. And we know that this is year 3, we're going to go back to the hub concept again. So it is an evolving model in terms of governance. Advocate community partners, because the largest stakeholders of decision groups, one is the Hispanic, it's the so-called the Hispanic population, the other one's Chinese population, run by 4 major IPAs. So they call it uptown, the other one's downtown, although they operate the same, but however, the committees pretty much together, but they do run something differently, in terms of engagement to the local provider group. In terms of committees, there are many committees in ACP, and just one lesson to learn is that, so for example, they have 10 projects. At the beginning, as of now, there's still like 10 committees just for each project. But however, it doesn't work because people are exhausted because there's so many committees, and some smaller organizations, they just can't handle it. So eventually, although you have many of the committees, they have to combine some of them, or some of the committees just no one shows up. So eventually, they will have to come up with a large group together, just put them, so when you have a large meeting, you might have 20, 30 people, and then you divvy up into 3, 4 committees. So in terms of practice, eventually they combine to less committees, functional committees. Staten Island is run very differently. They do have like workforce committee, the care management committee, IT, and operations. And actually, Staten Island is running one of the really top-ranked PPS just because they have a very, well, first of all, you need to have a really committed, experienced CEO. But however, also, it helps to be in a local area that you know everyone. It's different than, for example, like one city and like the advocate community partners in so many geographic areas, like all 4 boroughs. So you spread yourself quite thin, and there are many, many partners. Nassau Queens is another area. It's tricky. If just Nassau County, fine. But however, it's part of Queens, and Queens is a very diverse area. It has like 132 languages being spoken, so very different type of community. And then when you have 3 different hubs, it's very difficult to govern. So same thing as Suffolk. Suffolk has 3 hubs. It's hard to govern, but have a very dynamic CEO. So it is it keeps everything under control. However, I would say 2 hubs. So if you have top CEOs and COOs and the whole management team, 2 hubs is still better managed. It's easier managed than 3 hubs. So put it that way. And also, I can tell you with the 5 PPS, this is district year 3. I would say 3 CEOs originally started already not here. So, and also 2 COOs already not in the plan. So the turnover is huge. And there's trying to put it together is very fast-moving, very stressful, and there's a lot of competing interests. So we'll dig in a little bit more. And the committee structure is that I think, I can say, some of the structure is really, you have to set it up pretty tight at the very beginning so that you don't run yourself down, down the road. All right, so the next question, consensus building technique with stakeholders during the planning phase. Okay.
Grace, can I ask a quick follow-up question on your turnover comment? Did you see a lot of turnover at the board level as well, or was it mostly at the management team level?
I think management team level more than the board. The board, it depends on which ones. Well, I have to say that, some of the ones is that depends on how you connect it, right? So for example, like One City Health, the board members are from the corporate turnover is less than on the operating unit. Because it's almost like a startup, although it's not a startup. There's a lot of shared services. But however, so for example, like ACP is truly a startup. In terms of turnover, the original 2 IPAs, the same leaders are still there, but however, management definitely major turnover, and also because Northwell at the time is it's almost a fiduciary partner, and even that relationship didn't work out, and then it changed to a new fiduciary partner. Staten Island is very stable because they actually hired someone from the area and know both hospitals. Have been working in both hospitals before, know the community very well, so it's one of the most stable ones. Nassau Suffolk, just because of the county politics, the CEO was stayed for like a year and a half, and then they got on another search. And Suffolk run a pretty tight ship, always in top 5 PPS, always one of the poster boys. The CEO left 2 months ago to Northwell. So in a way, retention is really important. Turnover, not just the top rank, even for the analysts, project managers, the turnover is very high for all these. We can talk a little bit later in terms of lessons learned, how you keep them in the division, how you set it up. It's kind of important, which I can address to the second one, consensus building technique in the planning phase.
Perfect.
Yeah, answer your question?
Yep.
Okay. So in terms of consensus building technique, how to organize the work groups. When you see one PPS, you see one PPS. They all different. It really depends on the culture, the geographic area. I think that also, when you have too many work groups, as I said before, when you spread too thin, things might not work. And also, when you're trying to consensus building, inclusiveness is really important. But if you want to include everyone and transparency, when you start building multi-stakeholder, as we starting like BHIP, I told you before, the Brooklyn Healthcare Improvement Project, although that particular one, why I'm not talking about it, is because we built a beautiful group. It took a long time. It's not to build a cohesive team takes a lot of effort, and I am sure that you all experience this. For that, there are like 6 hospitals, 9 insurance companies, 30, 40 different, organizations, community-based organizations, Department of Health, etc. So the things that when you build a thing, it's a build from the ground up, is that because everybody have their own interests, their own priorities, and how to get everybody travel the same speed and then to the same goal, it takes time to build. And transparency becomes really important, inclusiveness. So when you have to set up too many work groups, then it's going to be very hard to include a lot of people because people spread out so thin, and there's so much to do, and you're constantly trying to beat the deadlines. There's many, many deadlines. And also in terms of, report submissions and the different demands. So the conversation, the way we're trying to do is that in order to plan for the future, because one of the things is that trying to get folks engaged as well as retain your staff, is that to understand this is not, it's more than just a grant. It's almost a building for the future for sustainability. It's not like, after 5 years and 3 years and then the money will be gone and that's what happened. A lot of time people, they left saying that, okay, you know what, this is year 3 now. What is going to be my future? There won't be any money left. But however, if you start the very beginning, the discussion saying that this is going for the future and actually all your plans is going towards that direction, I think things will get a lot better. And when people see that this is the direction you're going to and it's working, then I think that you would have a better retention and better engagement. And also, talking to a partner is really what is not just what's relevant to what the organization wants and what is relevant to them as a partner, and to see their role, how their role can interact with your organization. I think that that is really, that piece is really important, and that I see that it felt again and again in some of the PPS that I'm part of. And what, I was part of, put it this way, and even with this particular organization, we are trying to think that, look, we really need to do a different way to engage our partners and then make them really feel like they are not just going for the projects, where they're really looking to the partnership more holistically. So is that for this answer?
Great. So we want to pause for a quick minute here because I think this would be an area where the group might have a few questions.
Sure.
So if, operator, if you want to, patch anyone in who has questions at this point.
We're showing no questions at this time, but again, to ask a question, please press *1 on your phone, unmute, and record your name at the prompt.
Okay.
Let's keep going, Grace, and then I think if the questions come in, we can always pause for that.
Okay.
Thank you.
All right. The third one is how were elements of clinical integration woven into your projects. This particular one is that I could give an example. There are many ways of trying to get our partner engaged in terms of clinical integration, but of course there's also a lot of landmines too. For the clinical integration piece that we try to do, so for example, primary care and behavioral health. How do we get them engaged? Now, within the hospital, if you are part of a healthcare system, it's a lot easier. What you try to do is that you would try to integrate with existing workflow, because anytime you create a new workflow, it's very difficult. And then if you can build this in and tweak existing workflow, it can somehow, you can incorporate that in there. So for example, like One City Health, H&H, you have that many sites, and then now, it's already more than 15 sites. They already have co-located primary care and behavioral health. Now, but however, there are a lot of community partners, and I'm sure that in Washington, you have many, in a very remote area. How do you incorporate that into your daily workflow? How to clinically integrate, to your project. So what we try to do, so for example, stick with the primary care and behavioral health. And we know that even in the city, there's not enough, you never have enough clinical psychiatrists, especially pediatric sites. So what we're trying to do is that trying to figure out a way, and also, for the PCPs, a lot of times they don't really want to deal with psych cases. So what we're trying to do is that trying to have handoff through the project manager, trying to have our, with the project team and the PCP trying to meet together and try to set up some kind of protocol to make their work easier, not an extra layer. So we might want to say, okay, if in your practice there's no space, what we're going to do is that we might be able to say someone can come here one day a week so that you can, all the appointments, after you done the PHQ2, PHQ9, you need to have a warm handoff to a clinical person, a site person. Then that day of the week, you can go to meet with them, and they can give you all the consults. Or we can do e-consult or telehealth. So that is something that we were trying to do right now, with the community partners and to try to build into the workflow. What we do see is that some of the projects, if you think that you create something brand new and then this is not in the daily process, it's just not going to get done. And then, even you can go around for a long time, it's not easily acceptable. Now, how do you know that you were successful? We know, sometimes we don't have immediate results to know that we're successful. A lot of time we can say, okay, we do have metrics. We do have some success stories. We know what we did. So for example, like asthma, like asthma project, we know that we have been going through the primary care, so make sure the primary care will refer the patient to our partners for home remediation. So now we know that, before we don't have this protocol, now we know that we have more than 50% refer rates, and they actually get seen, and then after get seen, 74% of the patients of that pot actually would have home remediation done. So that is something that we know that we have outcomes to show, and that we have grateful patients is that they actually have someone out their own pocket, going to their home to do an assessment or clean up or something. So that is something that we know we do. That's more obvious, but some of the things we don't. So
Grace, quick question here. Were you guys mostly relying on sort of the DSRIP measures provided by the state, or did the PPSs come up with some of their own measures, either at the PPS level or the practice level?
We actually we rely on the state level, but also the way we plan to do it is that, okay, DSRIP has a lot of metrics. It's actually required by other VBP contracts, like the managed care companies, and also, required by, for example, our MSSP ACO. So, and then we know that certain things might work. So what we're trying to do is that trying to incorporate a couple of things. But then majority, I would say for the 5 PPS, they try to focus on what district require and some. So for example now, like the asthma that we talk about, this is something that is in the project plan, in the One City Health is a project plan. And we actually think that what we're going to do to improve pediatric asthma. And then, we would say, okay, by that time now we know that we have like 17 sites already went live. And then we would say acceptance of home-based visit asthma patients, what is the national level. So we're trying to have some national benchmark. So it's a little bit more than just district. But of course, all the district metrics, we want to make sure that we address that so we can draw down the maximum dollars. Did I answer your question?
Yes, perfect. Thanks, Grace.
No problem. So that is something that we do. Now, in terms of, like, for example, we have clinical redesign, like a palliative care. Then we will know that how many % of people actually they will get healthcare proxy. Before, the thing that we never even track, they never even get, but now we actually get them. So we know that we have metrics, but patients, the patients see the success. We can't really definitely say that, only anecdote. We will wish that going down the road, we probably need to do a patient survey.
Now, knowing that fact, Grace, would you have suggested that the PPSs incorporate the patient surveys early on?
I think that knowing the fact is that they should incorporate feedback from the patient, meaning that is it better, give them better ways to do it. So that is something that we learn through the process. Also in a BHIP grant too, when you do something, you have a survey, we actually did like 11,600 survey of patients in the ED, why they use the ED. I mean, if I'm going to do the same thing again, if we make some change, some intervention, I would like to know if the intervention helped them besides just reduce, ED visits, but then what else we could do to help them. So that would be more impactful.
Perfect. I think that was all the questions around governance and stakeholder engagement. Quick check for questions from the participants. Again, you can just press *1 if you have questions. If not, we will move forward to the funds flow and financing piece of the webinar.
Okay.
And we're still showing no questions at this time.
Okay. Funds flow then. The background on the existing Medicaid payment process when projects were started. I think that this is this question. The Medicaid payment process, I would say in terms of the Medicaid perspective, fee-for-service, for Medicaid, that wasn't anything carved out. For managed care company, I mean, in New York, probably 85, 90% now, Medicaid population is already in managed care. I would say still there are certain payers out there, they carve out mental health separately. Although there are more and more now try to say, okay, we're going to pay the same way for behavioral health and physical health. So, for example, like Beacon Health Strategies, Beacon Health, certain companies, they just carve out to a mental health vendor out there. So in a way, it's still not really totally integrated. So it's a mixed bag. So I don't know if I answer the question or I understand the question thoroughly.
No, I think you've provided the context. You know, in Washington, some of the similar challenges that were there in New York is based between the different payers as they, you know, pay for services for physical health versus behavioral health.
Okay. So the state of New York flow of payment structure, the flow of payment can be, so I will address in two levels. One is funds flow from the state for DSRIP. It comes directly. The state basically flows the funds directly to the PPS. Now, the second piece is more complicated. Different PPS float funds have different funds flow methodology. They are different. So I can go back to the 5 PPS that I was and I am still involved with. So for example, at One City Health, the beginning of their phase 1, phase 2, and I'm working on a phase 3 contracting strategy. Phase 1 and phase 2 is really project-oriented. So the fund flows to the partners based on what metrics do they meet. So a partner will have a schedule of all the metrics, and each metric will have a dollar amount attached to it. So once you meet the metrics, then you will get paid. If you don't meet the metrics, you don't get paid. Of course, phase 1 and phase 2 are very process-driven, not outcome-driven. So one partner saying that I'm in project asthma, and they would deal with the asthma. If they are in palliative care, they will be getting a palliative metrics. So there are a lot of metrics, a lot of work, and many, many levels of approval process. So phase 3 contracting is a little bit different. We are trying to finalize this right now, trying to more towards so-called partner type, what type of partner, trying to look at the partner more holistically and try to figure out how to contract in a way that position ourselves for the future VBP environment. So for ACP, advocate, it's very different. Beginning, it goes using attribution, and then later on, it's try to figure out, some of them don't have attribution because you can have community-based organizations. They don't bill Medicaid. So they provide maybe legal service, they may provide transport, food delivery and stuff. So there are different methodologies for different partner types. So for example, nursing home would have a different nursing home strategy, contracting, PCP are paid differently, hospital are paid differently, et cetera, et cetera. Then you go on Staten Island. Their approach is very different. At the very beginning, when we started with Staten Island, what we decided to do is maybe we should just have a budget. This is all our partners. Every partner was given a budget template and 5-year budget. Basically, you tell us what you can do and how to meet those metrics, which metric that you can meet based on this project. This is a project. These are a bunch of projects we have, and these are metrics we have. How much you can contribute, and you give us a budget. So what they did is that they put all the budget together, all the metrics together, and eventually they have a budget. So they don't have to worry about funds flow for a long time. They know the budget, how it looked like. For Nassau, Queens, and Suffolk, similar. And it goes very different. Well, I can't say similar because it's hub structure. So there's 3 hubs. So basically, each hub figure out a way how to fund the so-called, the key organization, the so-called the central office, then divvy up the money to different hubs. So saying that if you got, so saying that this is $1 million, so say 12 million goes to the central office, then, you know, with some kind of contingency reserve that you need to meet, you know, for operations, so $80 million or less, the $80 million, what you do is that you divvy up to the three hubs, depends on the attribution. And once they divvy up to the 3 hubs, the attribution, each hub, they could do whatever they need to do to engage their partners. However, the guiding principle is that we can't be so different that, for example, like PCP, we cannot compete in a way that, because everybody, you know, when you're in a one geographic area like Suffolk or Nassau, everybody's competing for the same practice. If you say, oh, I'm going to give you PM $5 PM, the other one say $3, and then suddenly you jack up all the price and then you can't afford to pay any of them. So basically, everybody just decided, okay, we're going to be reasonable, not to, you know, so that to engage our PCP so that it won't be in that kind of competition. The idea is that trying to get them engaged the PCMH, right, so that the whole PPS can earn the dollars, can meet the goals and the metrics. So it's a very different process and can be very taxing, especially, you know, like One City Health. Right now, you know, I was brought in and trying to do, you know, phase 3 contracting. Do you do a long-term contract? Do you do a short-term contract? So now, you know, maybe this phase 3, some of the partners they were there before should not be, they should be dropping out. They shouldn't be our partner. They won't be giving a phase 3 contract. There's a time to evaluate them, whether they can travel the road with us together, you know, to the VBP world down the road.
Grace, a couple of quick questions from your discussion here. For Staten Island, which or when did they ask the partners to provide the budget, which demonstration year? And then were the partners able to make changes to their budget year after year?
Okay, so what happened is that during the process is that once we get the award, it's actually year 0. You know, we don't go to year 1 immediately. So we are like lucky. Year 0, you pretty much know how much you're going to get. So during that time, it's the thing that 0 starts 2014, is it 14, 15? 14. And the thing is that during that process, during the planning process, once you start knowing how much dollar you have, you start planning to go through the budget process. Yes, after the budget process, you can make adjustments. Some of the partner may go out, some of the partner might not. You might have new partners joining in, so there will be there's a lot of reconciliation. Yes.
And Grace, the second question was, in your opinion, you know, which of these approaches you thought was most effective?
Okay. I would think it's a combination. I think that the Staten Island way to do it is that you definitely have a pretty good way to engage them at the very beginning and know your roadmap and engage them down the road. Now, but however, I think that you might need to do a mixture. I think that if you contract by partner type, not by project, I'm biased in that because once you go by project, so for example, I'm CBO. I can do asthma, I can do palliative care, I could do behavioral health. Which one do you contract with? If you contract by project, just one project at a time, then, you know, if I don't need enough, you know, I don't need another asthma provider, then some of them get locked out. So you don't really see them holistically. So I would say that I would like to contract by partner type. And then the thing is that once by your partner type, so for example, it's a nursing home. If you're a nursing home, I don't have to go through like 50 different metrics. I just think that, okay, if you meet the star rating, it would take care of a lot of the metrics so that, like, please, let's, reduce the workload, tracking metrics, and make real change on the ground. Because I think some of the contracting ways of tracking the metrics is important, but some of the things is that you spend so much time tracking that you lose sight that you are trying to transform the system, trying to move the system forward so that you can go for VBP. Another way is that by partner type is that trying to get them used to the way of contracting, so especially for like federal qualified health centers. Some of them they used to get, the federal qualified health center rates. They might not be contract with a lot of managed care companies. And the thing is that trying to get them on the road to do the way that you want to do it is kind of important, especially all the CBOs. If some of them, they would need to travel with you, and how do they ever even get paid, right? So it becomes important to have flexibility in terms of future state, how they contract. So it's almost like I would like to have, so if I have to do it again, I would like to have a budget. But in a way, with the budget, have the time to adjust that. For certain pocket, I want to have an exit strategy that say, oh, I'm spending too much now in this area, but for me to build the future state, for the VBP, there's certain type of services I don't have enough. In my geographic market, there's a gap, for example, for specialty. I need to reserve some dollars, some resource in that particular area. I'm able to move a little bit. So I would need to say, besides the budget, I will have a decent reserve for me to contract a little bit separately. Does that make sense? So for example, DSRIP, one thing about DSRIP that I personally would have a little editorial is that, okay, it's so much focus in primary care. If we want to reduce ED, to reduce emissions and ED visits, a lot of them, specialty care is really important. They are the ones, specialists, a lot of ones, they making decisions whether the patient needs to go or not to go to be admitted to the hospital. But some of the PPS, they don't want to, PPS, they don't want to do anything with the specialty. But I say that now I find myself, I said, okay, I'm here now. Find out I'm going to Health and Hospital Corp and the One City Health. One of the biggest access issue is specialty care. Now, how do I going to do that? I'm saying, okay, maybe we could have to think something out of the box. Maybe we contract for block time. We're going to contract for e-consult and telehealth. We have to do whatever we can so that the patient can get access to it. So I need to have a pot of money like innovation fund, something out there, to do that so that I don't lock in the budget. But the budget give you, reduce a lot of headache of guessing because you know pretty much what you need to do. But the budget is not for everyone because some of the CBOs, smaller organizations, they have a hard time to do budget. So it could be a challenge. So they might need a lot more help. Some of the partners need a lot of help. And what I'm saying is that some of the partners, not all the partners are equal. For unwilling partners, you might not spend all your time, for the smaller partners, you want to bring them along, but sometimes you might even need to help them to organize for you to deal with them because if you spend that much time for each one of them, you won't be able to meet you will lose sight of your goal to meet all your metrics.
That is helpful, and I was just taking a couple of notes along the way, and I think, the summary, what I gathered would be useful is really focus on, flexibility and equity, and then really focus on provider type versus focusing on the project type.
Yes, because project, there's certain things to do will help so many things in so many levels. When you're doing project, I know that there's certain innovation you need to do, like asthma, you have home remediation. This is a little project, a little bit different still. But then there are many chronic diseases in the care management, all that. It hits every single project. So, so that is the way, in terms of funds flow. Now, I think number 3, describe the most successful strategy for sharing information about the projects and the funds flow process during planning and into implementation and monitoring. I think that I said most of them. I did mention inclusiveness is key. Especially, I find out that there are many organizations when they're not at the beginning and they're not at the table, they could be very disruptive down the road. And some of them, they will exhaust to the political piece. Meaning that, oh, well, we don't know, and then you will spend a lot of time to do damage control. I think that you do want to, in terms of sharing information, you do want to experiment various ideas because, this is a perfect time for you to do it. And when you experiment ideas and then with your team bring them along, it will be easily for you to travel, to the new territory because they are part of the solution and they have their input, and I think that when you're doing implementation, it's a lot easier. What else I have to say? Okay, there are some of the things that we would say, certain things that it doesn't hurt to do a little bit more planning at the very beginning instead of backtrack afterwards. But however, don't spend all the time to plan and the process because it could kill you as well. Because I find out there are many groups, they just go to meetings. After meeting, before you know that, it's like year 3, guys. I said, well, what is happening? You haven't implemented anything, and then the thing is that the clock is ticking, you won't have any results, right? So you really want to experiment certain things. Care management, put it this way, care management needs to be at the table at the very beginning. You need to figure out care model at the very beginning because what is going to happen is that there's so many projects. They go on, they're still doing the project, but they're not connected to some of the care management piece, then it will not help you march towards the future state. So let me give you an example. So saying that some of the CBOs now, I won't name names, one of the PPS, engaged with the CBOs, and they do different projects individually. But however, not really connect centrally with the individual site in terms of care management staff. So saying that, oh, we have really good relationship, we do all the training, how can we have no patient ever refer to them? Because they never talk to the people on the site. They actually, the care management people, they can actually refer the patient. So the devil is in the details. So, for example, if I'm overseeing care management social work, inpatient, outpatient, when I have to refer a patient, I have a regular workflow. But then you say, this is a partners. If I don't even know who are these partners, what services they provide, how do my, my nurses social workers and care coordinators know where they refer to, and what is the process for them. If I refer the patient, we know that there's an outcome that comes back together. So really speaks to how you project manage them and your project management, how you bring the people on the ground with your project lead, and then the project itself, and then to make it actionable. And so that is something that's kind of important during the process of implementation, and monitoring whether it's working or not working. I think that the very beginning, people start just doing the work, and then the monitoring is not, if you're not tight, you don't know what works, what doesn't. And a lot of times that go back to the beginning, is that staff retention is so key, because a lot of time is that I would say in the lower level ones, so for project manager, analyst type, the turnover rate for some of the PPS that I've seen, by year 3, it's around 80%. High. It's really hard. So in a way, unless they know, that's why I'm saying that unless they know that they have a future, okay, they learn this skill set, now suddenly become consultants, they suddenly become someone else, saying that, they start stealing each other's, best staff, right? And the next thing is that you can't keep it going, and you can't monitor. So the process. So I think that staff retention is something that you have to think carefully. It doesn't have to do with age, by the way. The youngsters, they move, same thing with 50s, 60s. They still move, okay, in this whole process, just because there's so many turns, so many rules, so many changes. So you have to really figure out very clear vision, and the fact is that you're building something for the future, and that it will run even after 3, 4, 5 years, 6, 7 years. It's going to be better. Any more questions on that?
Operator, do you have any questions coming in at this point?
Still showing no questions at this time, but again, to ask a question, please press *1 on your phone, unmute, and record your name clearly at the prompt.
Thank you. Great, let's move ahead to the HIE and HIT part of this webinar, and then if there are questions that come through, we'll again pause for the questions.
Okay. This one is this one also is very different. The HIE area, it really depends on how is your setup. So, for example, if you are part of a large health system, you probably have your own internal, system already, and then you just need to build some so-called some extra, right, to track patients. But then project management is a tool that not most of the PPS has, so it becomes something that they would go and actually request outside help. Now, but the thing is this: when the HIE capacity, this is one of the hardest area for a startup. If you're a startup, it could be very pricey. So in a way, like ACP, they resort to cloud-based or someone they already have the system in place, because any IT project, as you know, takes a long time and very expensive. To just build it from beginning is difficult. And if you have to build it from the beginning, there are tools out there. Can you just set it up? But then you know that once they're trying to scale to a large cohort or population, you might have to go through upgrade. That's all I can tell you. So, for example, here One City Health, the largest PPS in New York State, it has a very robust IT system. However, whatever is happening, it is in the middle of changing from QuadraMed and different electronic health record to Epic. So it's itself going through a big system transformation, right, internally in the whole system. At the meantime, for the DSRIP, what they do is they say, okay, this is a very different population, very different partner. We're going to build a portal. So it built a very sophisticated portal, but however, we find out that, in this one, there's 193 partners, actually 209 partners. The partner, so one partner, so one city health and hospital court is considered as one partner, although, you're like $8 billion enterprise, and you have one CBO, you have 2 FTEs working in the CBO, that's another partner. Now, so in a way, it's a very different way. So saying that if certain organizations, it's very easy for them to use the portal, but then you find out after you build the portal, you need to hire 5 FTE just managing the portal because there are so many partners, they are technically challenged. And they don't know how to use the portal, and then after they use the portal, they submit the portal, and because the portal become a way to communicate, meaning that submit quarterly metrics, submit, including all the signature, all the approval, 5-level approval, eventually getting a check. So, but the portal is very tough. There are actually become certain partner just saying that I can't deal with it, I don't have the bandwidth to deal with it, they drop out. Now, but then there are extreme, they have no portal, no nothing, they just by hand. Now, the compliance, after a while, they will have a problem with it. If you're a large entity, how to track the paper flow and how to track all the funds, because there's a lot of funds, right? And then how to track each metric is getting very, very difficult. So this probably, I would say most of the PPS, not the most, the ones with the large system, even with the large system, they will actually do hire outside help to help them to figure out how to scale it up so that they can handle at least, for the duration of the project, they will have enough bandwidth to meet the goals.
Grace, one of the questions that has come up before and is an ongoing conversation in Washington right now is how much help can the State Department of Health offer, whether it's setting up a statewide infrastructure versus setting up a regional or a ACH-specific infrastructure. So do you have any thoughts around what is more effective? Is the statewide infrastructure with the delay in data effective? Or is it valuable for the ACHs to look at the regional HIE, HIT infrastructure?
Well, if their state can do things quicker, it would be good that there's a system that they can use so they don't spend most of their time to just deal with the IT. Now, in the IT, because IT, for example, like One City Health, you have a major IT department. So they can handle a lot of that. But if you're not part of that system, you're like a collaborative, it will be so important to have something like a CAM product that will help you to do things, and in the future when it's scalable, so that it will save you so much time. Because I remember when I was at ACP, the data book, it took expert. I think there are 3 of them working on it. They're like 50, 60, they have so many data books that they have to fulfill. It took them months just on doing that, and those are very pricey people. And once they go through the data book, you have to go through the whole RFP process, who to get that, and then after that, you have to make sure that you have the data people to do it. Now, for someone like ACP, the second largest, bandwidth is a big deal. How much resources are you going to do to build that out, right? So eventually, they will have to do something because they said, well, you know, we're going to go for BBP, the innovator program. So they will really have to build it up. Now, if the state can do that, can build it up, then the state could be a lot more, that basically if they can build for the state, that means it's scalable, right? You could use it, standardize it, makes things a lot easier, but right now it's hard. Like, for example, you have, you know, care management system like GSI. GSI, okay, fine. We could do it temporarily, but however, now we know that in 2 years or 3 years, we need a replacement because you can't do a lot of things that we want to do. So in a way, that becomes technology, so saying that if your district money ran out, what do? Right? Unless you said, okay, I already have an entity, we already set an entity that we can generate enough resources for us to build a new one, or unless you're attached to something. So I would definitely think that if the state can provide some guidance, even though a standard protocol, but less redundancy, you know, would be much easier, can just help them to do it. So, because I know, you know, even with big hit, when we had to build it, it would take so much to build that IT infrastructure.
Thank you, great.
It's a huge list. It's a huge list. It is something that I would say the leadership spend a lot of time and bring a lot of expertise and also a lot of frustration.
Now, large-scale technology projects can be very challenging, and you know, having experienced a couple of them myself, I can definitely relate to that.
Yes.
There was one question that had come up through the chat when it was around sort of, you know, a comparison between using clinical managers versus using community health workers. Do you have thoughts around which one would be more suitable and in any particular scenarios?
Okay. So it comes to, it depends on the population that you have. We find out that clinical managers, they could be, first of all, in terms of, they are pricier than community health workers, right? They're more expensive to hire. And the clinical managers, it depends on what level. The clinical managers is kind of important to so-called lead certain projects. But however, a lot of time you don't need all clinical managers, and if you have limited dollars, community health workers sometimes can open doors. So we find out that certain clinical managers, they are clinical, right? But however, they might not be street smart to reach the patient. So what we find out, like for example, for the asthma project, we basically work with 11 CBOs and have their people to work with the patient population to go into the communities to do that. So in a way, they will know their population so much better. And I don't know in your area, in terms of diverse population so for example, in Queens, there's 132 languages. In Brooklyn, this is like, what's that, 30, 50 languages, you know, being spoken. So in a way, if people from their own communities, it's a lot easier, and a lot easier for them to get accepted, not skeptical to do what we need to do. But I think that you know, there are definitely bandwidth issue in terms of community health workers. Sometimes do you want to contract them out, or do you want to just hire on your own? That is constantly an issue of debate, because I saw PPS, they have, like ACP, they hire like 50 community health workers. They become their trump cards, because what happened is that besides trying to engage patients, they actually trying to become almost like provider relations type of people, because, you know, if one metrics, if can get it, they can knock on the door with the doctor and then trying to get the metrics, so become the jack of all trades. Now, I also, you know, see PPS that contract with the CBOs, and then if there a project gets stalled, because CBOs usually they can hire 1 or 2 community healthcare workers, and each time you hire them, you have to train them, right? They have to go through the certificate program. And then once, if they have any issues in terms of grants, certainly they will lose a couple, and then your whole project stopped in that particular area. So you know what, if you can do it on your own, wonderful, but if you can't, you have to rely on the CBOs. That is a major risk for you to go into CBOs. Now, but CBOs, if they already have community healthcare workers, they've been in this space for a long time, that'd be great. But dealing with the CBOs, always, budget is always an issue, and depends on, you know, your relationship and standing in the community.
Perfect. Thank you, Grace. I'm going to quickly check for questions again as we're in the last 14 minutes of the webinar. If there are any questions, I think now would be the good time to ask it. If not, we will start wrapping up by looking at overall lessons learned. Operator, do we have any questions at this time?
We do have one coming from Melissa Haney. Your line is now open.
Sorry, thank you. Actually, the question that was on the WebEx was my question. Thank you, though.
Perfect.
Okay. So let me say lessons learned. There are many, many lessons learned. And top of line still retention of staff. It is, you know, I think that we talk about that already. If you don't have the staff, you can't retain them. It's going to be really rough ride. The second piece is that what we have to make, certain times you have to make tough decisions. Don't spend too much time actually chasing unwilling partners. Now, this basically goes through this attribution methodology. Some of the partners that you got, you never even heard about them, and then when you reach out to them, they said, what? They don't really want to deal with you, or you might try like 5, 6, 10 times, they don't want to deal with you. You know what? If you can't do that, there's a reason. We find out only afterwards. We spend a lot of time. Some of the either they are part of the other PPS, they have other deal with the IPA, they have something they just don't want to deal with. You'd rather spend time with the willing partners and then let the willing partners tweak some of the practices so that you can work together marching towards the goal. There are, the third thing with the saying, too many committees do not work. There are, you know, when you have so many committees, because I remember everybody's just saying, you know, you have just saying that, oh, we're just going to meetings. I don't know what we're doing. And, you know, we haven't seen anything change and stuff like that. So I think that if you do have meetings, make it meaningful. Make it meaningful, not having meeting for the sake of meeting, and more, you need to have, you definitely need to meet. FaceTime is important, but however, make it meaningful so that people don't think that it's wasting time, and then actionable. Whenever that you do things, make sure there's certain things that they care. Always look at, you know, for their point of view, you know, how would they perceive that, not just what we want. There are also avoid some bad habits. We'll call it bad habits. You know, at the very beginning when, especially when folks doing the planning, they want to be good to everyone. And the thing is that when they do the funds flow, what they're trying to do is that, oh, well, everybody, they're our partners. And we're just going to give them, their PPS, they just give them something. Once they start getting something, by doing nothing, you still give them something again the second year, and suddenly become an entitlement. The third year, want to drop them, you will have a hard time to drop them, and otherwise the noise will be so loud, although they do nothing, and you spend a lot of time. So make sure don't encourage bad habits, and then set the ground rule at the very beginning so that you can run a tight ship. The other thing is that it has to do with the system. So in a way, we talk about IT. It's a lot of, a lot of energy, and it will involve someone. It involves multi-levels of input. So in a way, when you do that, don't just rely on a couple of IT folks. Make sure the people in the operations are at the table, what they use for, they know what it is. Because a lot of time, folks build something, but however, certain key stakeholders, they never heard about it, and well, they're not part of the team, and they build something not what they want. So that is something that the lessons learned is that you're trying to invite whoever that needs to be there, not like 100 people, but I mean, care management must be at the table. People measuring metrics quality, be there. People, they have to flow the dollars, be there. And I mean, these are the people, people they have certain metric owners, okay, not metric owners, a project manager type, how to track things, and the network development piece is really important because what it is that people build something, they don't build for the future, they build for what's now, right? So, and the networks are saying that if you're going to build for the future, you want to make sure that, because network takes the time to build, you want to make sure that they are there as well. So those are the lessons learned. Oh, one more thing is that you can't be too conservative, by the way. Innovation is important. We find out that, people, they are so focused on the metrics, suddenly they forgot that they used to be very innovative. They do a lot of things out of the box. But then once they start doing DSRIP, they start just going for the metrics and going for the roadmap. The next thing is that they forgot innovation. So that's a lesson learned.
Thank you, Grace. I think this was a very informative webinar for all of us. I'm going to just give another last moment for any questions.
And then you just, I do have a page of takeaway. I know time's running out, but I think that most of the stuff they're already saying already, saying that hubs are very tough to run. But with great leadership, it's possible, and 2 hubs is easier to run than 3 hubs, as I said before. Transparency, inclusiveness, and education. Not everyone, they start in the same level. Education, we find out that there are many different, levels of understanding. Even what is care management has different definition in different folks' years. So you have to define and make sure that what is it. The training and also align the financial incentive and outcome. Real-time data performance feedback is critical. And also, for future sustainability, and funds need to be allocated to build infrastructure. I do say that some of the partners, they might not want to travel all the way. They just want to get the dollar now, and there are plenty of them. They just want to get their share. That's why they are at the table. So be aware of those. For VBP contracting, we know that non-hospital partners, they do need a risk-sharing platform. And, you know, when you travel with a group of coalition partners, you're always worried about antitrust. So it helps to apply for COPA at the very beginning. I don't know if that's in your state, but that is something that if I have to do it again, I'll do it at the very beginning, which actually we did do for 2 of the PPS when I was in Northwell. We did it for the Staten Island and ACP. I don't know if they finally get it, but now I'm at one city, so now it's like, oh, whoops, we need COPA. So it's a little bit late, but hey, look, we may still have to go to the state. And then the last one is enhance the investing innovation programs. They can change the paradigm. So that's all my spill.
Perfect. Thank you, Grace. We did have another comment. You know, there was a request for the slides. So we will make the webinar recording available with the 3 ACHs. So you can, you know, check with the 3 ACHs contacts and be able to get a copy of the webinar recording, which will include all the slides. So thank you. Grace, again, I want to say it was very helpful to have you give perspective on all the aspects. Yeah.
Thank you very much.
All right, everyone. Thanks for attending.
And that concludes today's conference. Thank you for your participation. You may now all disconnect.